Hi everyone, Dr. Kent Hungerford here, and today we're going to be talking about bunions or hallux valgus deformity. Really wanted to touch on this topic and go through basically what my protocol is. You should be able to access, if not already, in the coming days, a full pro forma on this as part of our South Coast Foot Surgery and Learn by SCFS treatment protocols for all conditions. So watch this way if you haven't already got it, or let us know and we'll be happy to send it through. So hallux valgus or bunion deformity is defined by the presence of that valgus deformation of the great toe, that hallux valgus as we know it. You know, there may be a varus deformation of the first metatarsal bone. So typically we see that as that increased intermetatarsal angle between metatarsals 1 and 2, as well as that medial eminence or the prominence of that first metatarsal bone head. And you know, sometimes we see a bursitis in this area, sometimes we see like a Joplin's neuroma, a ganglion from this area, and you know, that's not uncommon. But also that pronation of the great toe, so you know, where that sesamoid subluxation occurs. And that's why I really like having a bit of a look on that frontal plane as well, as we're looking through the foot, so we can see how much pronation has occurred. And it really should be stressed that this is not merely pathology of the first ray, but of the entire foot. And so we really need to, like I know we all do, have a look at sort of where the rear foot is, the midfoot, the forefoot on the rear foot, to make sure that, you know, there's not other concerns. But also the metatarsalgia, is that second ray a little bit more plantarflexed or dorsiflexed? And how might that be precipitating the occurrence of hallux valgus deformity? And, you know, whether that's asymptomatic, you know, whether there's symptomatic callus, all these sort of things can occur from hallux valgus and lead us to that, you know, the proper diagnosis of hallux valgus. When we start to talk about, you know, the classifications, you know, our standard sort of classifications is our mild, moderate and severe. And the images on the screen really show that and dictate or, you know, show what we're looking at there so that we can get a greater idea. But I wanted to share with you as well sort of where we're going with regards to those classifications in a little bit more of an advanced style. And I think one of the better ways to look at this is from an article by Hatch and Company. And basically they break it down into these 4 classes of deformity. And, you know, there's quite a lot of information on this slide. Feel free to, you know, pause it, really soak it in. But I think, you know, that if you're anything like myself, having a bit of a look at some more of those pictures will really give you a better idea of what we're really looking at, so that we can classify these a lot better. And these these bring in a lot of the radiographic side of, you know, interpretation as well. But the good thing about this one is that we do get a bit of a treatment recommendation depending on our physical assessment, as far as whether there's restriction of the joint, as well as our anatomic findings through there. So we can see through our class 1 here that the radiographs showing class 1 hallux valgus is no rotation observed on the axial view, whereas class 2A, the radiographs of class 2A showing eversion of that first metatarsal and the sesamoids still within their grooves, intact within that crista underneath. And just so that everyone gets a bit of an idea, you know, these are what we're talking about as these sesamoid grooves, with the sesamoids obviously being here. You can see that they're a little bit, you know, potentially sublux, but still within that groove. When we come through to a class 2B, we can see that there's rotation of that first metatarsal, that pronation potentially, with the subluxation of that sesamoid complex. And you can see those cristas where we're just not finding those sesamoids are staying within, you know, where they should be anatomically. We see within that intermetatarsal space on our DP image that again, they're not where they should be anatomically. When we come through to this class 3, we're really seeing that metatarsus adductus with no first metatarsal frontal plane rotation or that sesamoid axial view. So again, we're seeing those sesamoids within their cristas where they should be, but we're looking at that metaductus or those lesser rays in conjunction with our hallux valgus. When it comes to a class 4, we're really seeing, you know, starting to see a bit of arthrosis and change that hallux valgus, of the sesamoids. And, you know, this is where we're starting to see, you know, a little bit more of an advanced deformity occurring. Now, you know, that pretty much ties in, but how do we get there to start with? You know, I'm a big one for getting the right x-ray views, and I will always say, you know, exactly which views that I'd like, to make sure that, you know, we take the guesswork out of foot x-rays normal series. And I see that quite a lot, but, you know, here I am to empower us to make sure that we can learn how to give appropriate views, whether they're for, you know, the forefoot in this case, where we are getting those weight bearing, critical that it is weight bearing, dorsoplantar, lateral oblique, lateral and axial sesamoid. And as I mentioned, that axial sesamoid is really where we're looking straight down there. They may, depending on the clinic, have that toe flexed up so that we're seeing straight into that sesamoid apparatus. It's going to be going straight through the foot there, as we've seen in one of those these earlier photos. These are all our, you know, frontal axial view of the sesamoids. This allows us to really get a greater idea of how much arthritis is occurring at the first metatarsophalangeal joint. Now, for some patients, you may also have some soft tissue concerns, or there may be inflammation of the joint. You know, you're wanting to get a better idea, and in those cases, you may undertake an ultrasound as well to exclude that Joplin's neuroma, the ganglions, the bursitis. And, you know, of course, that's all up to clinical judgment. At times, you may also require an MRI if you're really not sure, or if there are other concerns going on. You know, there may be gout that you're wanting to get a better idea of, but typically, you know, these are the type of imaging that we would be undertaking. Now, when it comes to conservative management, you know, we can help to relieve the pain. Now, it won't stop the progression of deformity, and I think that's a really critical point here, that what we're doing is we're helping to manage the pain and the deformity. We're not necessarily correcting it. And so things that we can do that we know that can help reduce pain are those orthoses, to spread the pressure more evenly. You know, splinting can work, jury's out. I'm personally not a huge splinter myself, but when it comes to functional activity, if their patient's a sprinter, and I know recently I've reviewed a young lady, 12-year-old sprinter, and she finds really good benefit from using a splint for her sprint. And so she uses it very much just activity wise. Now, intrinsic strengthening to help increase the abductor hallucis and our interossei, you know, all that's going to be helping. And just gaining a greater broad biomechanical appreciation, of course, is important when it comes to the orthoses, but also their footwear and whether their knees, hips, lower back, you know, all those sort of things are impacted as well. There is the chance that a corticosteroid injection could help. These are the patients that also have that bursitis, capsulitis. They may have some gouty reactions, and they may not be in a position where it's painful enough for surgery, or they're unable to undertake surgery, but need something more than the sort of more conservative options that I've mentioned before. Now, as most of you will be aware, I'm a big advocate for low-level laser therapy, which is also called photobiomodulation therapy. And there'll be a further video on that coming in the weeks ahead if it's not already up. And basically, the low-level laser therapy increases the energy to increase the blood flow, decreasing that inflammation, decreasing that pain, desensitizing those nerves. And this is sort of looking at that sort of pain threshold, about bringing that pain stimulus down below that pain threshold so that patients are not finding pain. And the biggest thing that we can do, of course, is reassurance through that patient education. Critical to everything that we do, of course. So important that I've mentioned it twice. You know, inform them about the ability for surgery. And, you know, what we're talking about here is when to refer for surgery. You know, of course, milder deformity is going to have a greater success. But if there's no pain, there's not always the need to undertake surgery. And I suppose the way that I talk to my patients about this is I absolutely talk about the pros and the cons, you know, the relative risks, the recovery process, so that they have a bit of a better idea around that. Now, if you're not too sure about these, obviously, you know, give them rough ideas. To give you a bit of an idea around recovery, most of my patients are back into a jogger at 4 weeks. but are in a post-op shoe until then. And typically they're going to be undertaking, around 15 to 20 minutes of activity as tolerated initially. But most patients were under that. I just encourage them to be walking, at least once an hour, even if it's just to the fridge and back to the couch, so that we reduce those risks of clots and, the swelling associated. But most patients are getting back to it. It's just that it can take a little bit longer for some others as well. When people are in a desk job, it's typically going to be 3 to 4 weeks if they can put their foot up. But for those that maybe like teachers or our tradespeople that are on their feet for longer, we really need to have that earnest conversation about it potentially being 6 to 8 weeks of recovery. Now, of course, larger deformities mean greater recovery, greater risk, and maybe the potential need for a fusion. If there's no arthritis, I'm always going to try and enable us to undertake a joint salvaging procedure where we're going to be keeping that joint rather than fusing that joint. And that very much comes down to the patient's symptoms and what their x-rays are indicating as well. Less often for a larger or, significant deformity am I going to do a minimally invasive approach. And so, having a view of that joint in these larger bunion cases is going to be a bit more critical to getting that greater outcome. Consider trialing the conservative. Always exhaust the conservative is the appropriate way to go. But if there's no resolution, discuss surgery further with your patients. Give them that option to say no or to say, yes, I'd like a bit more information. Talk about the pros and cons as you see them. And of course, if you're unsure, refer for an opinion. There's no strings attached. We're not there to book every single person in for surgery. We're there to give patients the outcome that they need at the time that they need. And that may be that I push them back and say, no, I'd like you to go back through to your current practitioner, your podiatrist, and potentially have a look at some further custom orthoses or look at these strengthening exercises because you're not in a position where you need surgery at this stage. And patients are pretty happy with that type of discussion. They know whether they need surgery by the time I go through the pros and cons, and it's more about just working out when's an appropriate time for them to proceed with that. Now, when we look at surgical management, it's really good to get a better idea of how we undertake the procedure. We talk about distal or proximal metatarsal procedures. We talk about just fixing at the hallux, the minimal incision corrections or the open. And then we've got other options as well, which are a bit more indirect. And we'll come back to the extraosseous talotarsal system via hypercure as a bit of a left of field, lesser known, but potentially an effective option in more conservative cases. When we talk about these distal procedures, we talk about that chevron or Austin osteotomy, and this is what we're talking about here. This can be done open or minimally invasive, and basically we're just moving this distal fragment metatarsal head to the lateral side so that we can close down that intermetatarsal angle and correct that hallux valgus angle in doing so. Typically we use 1 or 2 screws in doing this procedure. Our Isham procedure is available as well, shortening and lifting the metatarsal head so it's not as plantar flexed. And then of course distal procedure could be for a large bunion or someone that also may have some hallux rigidus involvement, arthrosis. We're looking at that fusion procedure of that first metatarsophalangeal joint. We can also look at some full length procedures, whether they're a scarf osteotomy, and you can see through here that it's a scarf is a Z osteotomy with our 2 screws being placed there as well. When we look at more proximal metatarsal procedures, we start talking about our first metatarsal cuneiform fusion, particularly in patients that have got a real lot of hypermobility. This can be a potential option for them. This is also an option for those patients that have recurrent bunions, and depending on the radiographs and our clinical assessment, this procedure may be recommended. Yes, there is going to be a longer recovery process as we're fusing a midfoot bone now, and having a bit of a chat to the patient about those options too. This is a procedure that is lesser undertaken, and it is really important to make sure we get the right patient when we do this. One of the other procedures that we can do is an opening base osteotomy. This is going to help close down the intermetatarsal angle by just bringing that metatarsal across from a more proximal level. And there's particular plates that we use to ensure that we're getting really good coverage there as well. When we start talking about hallux procedures, some of the distal metatarsal procedures are done at the same time as our hallux procedures, and one of the most common ones is this Aiken osteotomy. And you can see here that we've made a cut through that proximal phalanx in a way that's going to help close down this hallux abductus angle and the interphalangeal sort of angle there as well, to make sure that we're really reducing that degree of deformity. Now, other things that we can do is this interphalangeal joint fusion, and there's a few different ways to fixate that as well, depending on the patient. We can also use staples there, for instance. When we start talking minimally invasive or open, obviously I'm quite towards the minimally invasive when we can get away with it. I just find that we get really good repeatable outcomes. And you can see here that we've got a pre-operative and a post-operative image. We've really been able to close down that intermetatarsal angle. Hallux is in a much nicer position. And this is a patient of mine that is 2 days post-op. She had a bit of bleeding, so she came through at that 1 day, and it's obviously corrected well. But there's very minimal swelling at that 1 day. Patient's quite happy, not too much pain. When we start talking open, obviously this is a larger deformity, and that's why that open approach was decided. And you can see here that we've done quite a lot of resection of that medial eminence, as well as moving the metatarsal head laterally, correcting that proximal phalanx. And in this case, we've also done a proximal interphalangeal joint fusion and a second metatarsal shortening procedure as well. So that, the before and after, obviously quite a good result for this type of patient. But when we're going to those more severe cases, now this is sort of, worst case scenario as far as open and correction. And this patient had quite a lot of surgery undertaken secondary to a rheumatoid forefoot, large hallux valgus. Previous procedure hadn't worked as well as what we had hoped. And we can now see that we've had to do resections of all the metatarsals, all those proximal phalanxes, and then looking at wires in place for an extended period of time. Now, this type of patient's not an everyday type patient. You see some of our patients come through and there's a lot going on. It's more often when we do have our extreme pathology and our very much plantar flexed metatarsophalangeal joints. These are the sort of patients where you have a really long chat about that recovery, and these wires may have been in the foot for even 6 to 8 weeks some of the time as well. For this lady, it was about 6 to 7 weeks to make sure that we have that correction longer term. Now, that other option that I talked to you about was that extraosseous talotarsal stabilization system, and basically what we're looking at there is the Hypercure implant. And the way that this works is it's an implant that's placed through the sinus tarsi in the subtalar joint to really act as a saddle to to stop that medialization of the subtalar joint axis, basically bringing it back into a lateral position so we don't get that full flattening of the arch. And you can see that before and after really clearly in these images here. Now, the studies sort of indicate that we're decreasing the intermetatarsal angle by about 5.7 degrees on average in appropriate patients that are chosen for this procedure. And so that's where I'll sort of say, there's these concerns that we've got, and, the flat foot being a big part of that. And I can sort of give people a bit of an indicator of, maybe their bunion may be better treated indirectly whilst treating their flat foot at the same time. And so we, again, just weigh up those pros and cons and say, this could be a good procedure for you if you're looking for that one procedure to fix as much as possible. As always, if you want more information, feel free to send me an email, get in touch. Have a little bit more of a look at our website for further information as well. But we're always here to chat. We'll see you at the next one. Thanks.